This is our depression PowerPoint. What is depression? A mood disorder that causes someone to feel sad, irritable, or hopeless. Can affect sleep, appetite, or relationship. Can cause loss of interest in activities that were once enjoyed. Can cause thoughts of suicide. Affects physical, emotional, and social development. The symptomology is a very long list, but here are a few: feeling sad, hopeless, or irritable a lot of the time, not wanting to do or enjoying doing fun things, show changes in sleep and eating patterns, eat a lot more or a lot less. So, show changes in energy, being tired or sluggish or tense or restless most of the time, having a hard time paying attention, feeling worthless, useless, or guilty, showing self injury or self destructive behaviors, crying more often, increased sensitivity to criticism or other negative effects, and more irritable mood is common in the children. Extreme depression can lead a child to suicide. For youth ages 10 to 24, suicide is among the leading causes of death. Diagnosis and test. USPSTF recommends screening for MDD in adolescents 12 to 18 years of age. You can use the PHQA or you can use the Beck Depression Inventory for Primary Care, which consists of 7 questions. Diagnosis include physical exam, lab test, CBC and thyroid, psychological evaluation. Diagnosis is most commonly made between the ages of 12 and 17 years of age. Depression diagnosis was 4.4%, which is about 2.7 million children ages 3 to 17 years old. To be diagnosed with major depressive disorder, a child needs to show at least one of the following symptoms for most days of the week, for most of the day, during the same 2 week period. And these are persistent feeling of sadness or irritability, loss of interest and pleasure in all or almost all activities once enjoyed. This is Beck's questionnaire, and mild symptoms start at 4 points.
Management team for patients and family. Pediatric practitioners. Depression screenings for all adolescents starting at the age of 12. Therapists provide therapy for cognitive behavioral therapy or CBT. Social workers give the parent a sense of what they are seeing in their child. They help the parent with resources within the community. They explain to the child who at school can help and how they can help. They recommend professionals who to talk with and help the family with relationships. And psychiatrists if more complex treatment is warranted.
Plan of care, follow up, and reevaluation. Treatment must take into consideration severity, suicidality, developmental stages, environmental and social factors. Non pharmacological would be CBT therapy, family therapy, exercise, spirituality. Pharmacological is included in the following slides for moderate and severe depression. Combination of these treatments are also used. Education, educate in depth on risk for self-directed violence, chronic low self-esteem, in-depth education on use of medication, side effects of medication, including increased risk of suicide and length of time it takes for medications to work. Anticipatory guidance, continue to monitor for safe behavior, provide family time and interact with child, limit screen time to less than 1 hour per day, create sleep patterns, allow child to express feelings, praise children, and set boundaries. Follow up 4 weeks after start of treatment. Children younger than 11 years old or with chronic depression, comorbid substance use, psychiatric disorders, suicidality with a plan, and lack of parental engagement in treatment should be referred to a psychiatrist. Reevaluation, monitor 6 to 8 weeks prior to beginning treatment. Then every month after starting treatment or 4 weeks. And this will go up to 2 years after remission.
Medication and the positive and negative aspects. The FDA has approved 2 medications for adolescents and teens for depression: Prozac, which can be given to children 8 years old and older, and Lexapro, which can be given to adolescents 12 years old and older, have been approved for major depressive disorder. The positive for these SSRIs, or selective serotonin reuptake inhibitors, combined with cognitive behavioral therapy, or CBT, have the highest likelihood of reducing symptoms or achieving remission. These do come with a black box warning, however. Increase in suicidal thoughts or behavior in the first few weeks after starting medication or changing the dose in some children, teens, young adults under the age of 25.
For anticipatory guidance, it is important to emphasize to parents the importance of positive attention. This includes smiling at your child, making eye contact, using facial expressions, and physical touch. It's also important to promote self-regulation. Supervision is another important aspect by always keeping a close eye on your child's safety. Behavioral changes to be aware of include agitation, loss of motivation, lack of interaction with peers, isolation, or speaking slowly. Discipline techniques include providing a daily structure, developing a rewarding system, positive support, providing reassurance, and establishing health rules. Sibling wellness is also important, as it's important to check on all of your children, and some families may even consider individual or family therapy if necessary.
Resources for parents. The first resource is the Substance Abuse and Mental Health Services Administration. They have resources in both English and Spanish. The hotline is free to access, and they offer resources for family members after suicide attempts and mental health crises. The next resource is from the American Academy of Child and Adolescent Psychiatry. They have information ranging across all mental health conditions, including depression, for parents. The Society of Adolescent Health and Medicine have many resources put together regarding adolescent mental health and their parents. Parents can go to these sites with or without their adolescent. The Check-In Project gives parents ideas on how to talk to their children about their mental health. And finally, the California Mental Health Resources for Children and Parents gives hotlines for adolescents to call, ranging from depression and suicide to LGBTQ+, and parent education about suicide and depression, stress relief, and how to talk about mental health issues with their children.
These are a few of the resources we came across for healthcare professionals. The first one is the American Academy of Pediatrics, in which they have a training and educational program for mental health. The second is by the National Alliance of Mental Illness. They have a behavioral and mental health provider educational program, which helps to improve the quality of behavioral and mental health delivered to children in the community by equipping healthcare providers with educational tools and resources that are needed. And lastly is the PeerRx Med. This is a free peer-to-peer program for physicians and healthcare providers, in which they offer support, connections, encouragement, and resources to help build skills and for optimal well-being of the healthcare provider.